My name is Jeremy Myers. I'm a reconstructive urologist at University of Utah in the Department of Surgery and the Center for Reconstructive Urology and Men's Health. And what I wanted to talk about today was some background about urethral stricture disease. This is a condition that's fairly rare, but we do a lot of these surgeries at University of Utah, and it's very helpful sometimes for patients to gain some background knowledge about urethral strictures if they have this problem. So I'll be going through a slide set of some background information about urethral strictures. Not all of the information on the slides might pertain to your particular case, but it gives some general information about the causes of strictures and what we do to treat strictures and how we diagnose these strictures. This first slide is about urethral strictures and what the hypothesized cause of these strictures are, or the theory behind the cause of many of the urethral strictures we see. And you can see depicted over here the normal urethra, and then the normal urethra has some kind of insult. Either this could be a trauma, a bad infection, or something that we don't really appreciate as the cause for an injury to the lining of the urethra. Then the high pressure urine going through the area cracks the area. It's essentially like a very bad chapped lip, but in the urethra. And the continual urine and cracking and high pressure urine going through the area perpetuates a scar which becomes very dense and very hard to cure. This is what we refer to as spongiofibrosis. What are the causes? Etiology is a medical word for causes of stricture disease. And in the past, urethritis, or an infection of the urethra, was a predominant cause. But now with antibiotics, this is relatively rare. And so in contemporary times or current times, mostly these are caused by iatrogenic or procedures. That means a medical cause. And this might be a hypospadias repair that was done, or some type of procedure on the prostate that was done, like a transurethral resection of the prostate. And then the other leading cause is what we call idiopathic. This just means no known cause. And the majority of patients we see seem to have this, especially when they're younger. Then urethritis is a relatively rare cause of urethral strictures currently. How do patients present? What are the symptoms of strictures that patients might have? And we've recently appreciated actually that urethral and bladder pain is one of the primary presenting problems and one of the real reasons that patients pursue urethroplasty to fix their strictures. Urinary tract infections is the second leading problem that patients have, and the incidence of this might as well be 40 or 50% of patients. And then younger patients that are diagnosed with quote-unquote prostatitis, and this really goes back to pain. They have some kind of urethral or prostate pain, and other doctors diagnose this as prostatitis or inflammation of the prostate. LUTS means lower urinary tract symptoms, and this might just mean irritative voiding or having to get up and go to the bathroom frequently, or having urgency of urination. In other words, when you feel like you need to urinate, you better be near the bathroom, or you could even feel like you're going to have an accident. And then also having very abnormal flow or very slow flow is an obvious problem that patients have when they have a scar in the urethra. This was a paper that we worked on in collaboration with several other centers around the United States, and was looking at this problem of lower urinary tract pain and urethroplasty. And we just asked men whether they had pain in the bladder or pain in the urethra, and how frequent this was before and after urethroplasty. And we found, just like I mentioned before, that a lot of men have either bladder pain, 40% before urethroplasty, or urethral or penile pain, 71% had some degree of this pain before urethroplasty. So a question that patients often ask me is, will the pain be better after urethroplasty? And fortunately, our data really showed that the pain did get a lot better. You can see bladder pain resolved in 74% of the cases, and in another 4% of the cases it was improved. and then urethral and penile pain resolved in 64%, and in another 17% was improved after urethroplasty. So this is one thing that we consistently say, is that in the majority of patients that have significant pain as a result of the stricture, if they undergo surgery to fix the stricture, the pain usually resolves or improves. How do we make the diagnosis of urethral stricture? An obvious part of the diagnosis is patients that have low flow. And when a patient goes into a urologist's office with urinary problems, often the urologist will measure the flow, and this will be a clue. In young men that have strictures, they have profoundly low flow, and this can suggest a stricture. Most of the time, however, men are diagnosed based upon a cystoscopy, which is a flexible scope, kind of like a catheter, that's inserted via the penis into the urethra, and we visualize the narrowing in the urethra. Once a stricture has been found, often an X-ray will be done. This is called a retrograde urethrogram or avoiding cystourethrogram, and this will show how long the stricture is and what the location is. Because often when you undergo a scope procedure, we just see the very beginning of the stricture, and we don't know if it's just a small stricture, maybe a centimeter in size, or is it several inches long. This is what a scope picture of a stricture looks like. You can see the dramatic narrowing, and this is really just a pinhole that a patient's urinating through. It's really amazing that men can urinate through a very tiny opening in their urethra. This urethra should be about as big as this entire view of the scope, and so you can see how dramatically narrowed it is. This is how a retrograde urethrogram or avoiding cystourethrogram is done. There's injection of the contrast dye into the urethra, and then X-rays are performed, and this will show where the narrowing is along the urethra. So here's a typical small stricture, and what you can see here is this is narrowing that's normal, and it's associated with the prostate and the sphincters. The sphincters are the muscles that keep the urine within the bladder. But this should be, along here, all the same size. And you see a dramatic narrowing in that pinhole that I showed you on cystoscopy. And this is where the scar is. So what do we do when we find a scar, urethral scar like this? And most men are going to be managed first with a scope procedure or a dilation. So the scope procedure we call a DVIU, and that stands for Direct Vision Internal Urethrotomy. And in essence, a urologist under anesthesia will place a scope right up to the scar and then very precisely use a tiny knife that comes out of the front of the scope and cut the scar. And that breaks open the scar, and then they leave in a catheter of reasonable size and hope that the scar heals over the catheter and the scar doesn't narrow down again once the catheter's been removed. The advantage of this is it's done under anesthesia. Patients don't feel much pain with the procedure. Another way that these strictures are managed are just dilation. And in this procedure, a urologist just inserts some plastic dilators or a metal dilator up to the area and breaks the scar open. The advantage of this is it's done in the office, so you don't have to undergo an operating room procedure with anesthesia. But that's also the disadvantage, is that it's very painful for patients to undergo, and it can be quite traumatic in some patients. This is what a direct vision internal urethrotomy, or what I refer to with patients as an internal cutting procedure, involves. And here you can see the area of scar, and we just have a little green wire going through it to kind of keep it open. And then this is a knife that's kind of like a circle. You can see it's got a little bit of a blade that's inserted through the scar, and the scar is cut at 2 or 3 locations to really open it up, and then a catheter is put in, usually over the wire, to allow the urethra to heal. Typically the catheter is left in anywhere from 3 to 7 days, can be left in longer, then the catheter is removed, and then we see how patients do. Unfortunately, we now know that these procedures are rarely successful. This is a paper from South Africa that was published back in the 1990s, and it's really one of the best papers on urethrotomy or the internal cutting procedures. And they took 210 men and they followed them. They did either the internal cutting or dilation. They found no difference between the two. And every 3 months they did catheterization and also this retrograde urethrogram. They followed the men on average for 24 months. They found that longer strictures had a higher failure rate, which is no surprise because it's a more serious scar. They also found that the stricture-free rate was 30% at 48 months, so not very promising. But most of the patients had had previous treatment. So what about the patients coming in with a first-time stricture? Because those are the patients that we might expect this to work and they could avoid urethroplasty. They did a sub-analysis of the 80 men that had never had a urethroplasty and never had an internal cutting or dilation. And they found that the overall success was 28 out of 80 men, or 35% at a 4-year total follow-up. So pretty good. Any man would decide to undergo one of these internal cutting procedures if they had a 1 out of 3 chance of avoiding surgery in the future. The surgery is more invasive, as you'll see later on in other videos, and you have to recover a lengthy time, usually about 2 to 4 weeks afterwards, so a longer recovery. Unfortunately, more contemporary literature and studies have shown that the urethrotomy is not as successful at 35%. This was a paper from Detroit by Dr. Santucci, and he found out of 76 men treated at his institution, only 6 were stricture-free, 8%, and the median or the average recurrence was right around 7 months. So there's some discrepancy in these different studies. I think probably in reality the success rate is somewhere in between the two, and I usually quote men about a 20% chance of a first-time limited scar in a certain area of the urethra at being successful with just an internal cutting procedure. So we talk about this in clinic when patients haven't had previous treatment and patients decide whether they want a successful but more invasive surgery versus they want to try the internal cutting surgery and follow things very closely and then go on to the more invasive surgery. The only downside of the internal cutting surgery is that it can make the strictures longer, and also in some men that maybe don't have the best access to health care, it may be best to just do the most definitive surgery and fix the problem with the highest chance of long-term success. Ultrasound is something, if you come into clinic and we talk about urethral stricture, that we do. The retrograde urethrogram tends to underestimate the urethral length. And so we always do an ultrasound before the surgery after patients are under anesthesia. The reason that we wait is that it causes some pain for patients to do the ultrasound. And so we do it after anesthesia in cases where we're not sure about which surgical approach we're going to take. The reason that the retrograde urethrogram and voiding cystourethrogram underestimate the size of the stricture is that you have this kind of oblique or angled view. So the x-ray comes down, but the urethra isn't dead perpendicular, and so you tend to look down the barrel of the urethra. And sometimes you can really underestimate the size of the urethral stricture. The ultrasound's done by retrograde or injecting saline down the penis while the patient's asleep, and then we put the ultrasound perpendicular to the scar, and we can very precisely measure how long the scar is. The importance of this is for longer scars, we can't just cut out the scar and reconnect the urethra. You can imagine if you cut out a scar that was an inch or an inch and a half and reconnected things, then when the patient had an erection, they would be bent over like this, and it wouldn't be a very good outcome. We can usually cut out scars that are up to about an inch in size, and if the scars are longer, then we have to rebuild the urethra. And usually the way we rebuild the urethra is with a strip of the inner cheek. That's what we call buccal mucosa urethroplasty. Buccal mucosa because that's the name of the lining of the inner cheek. The medical name is buccal mucosa. So here's a good example of the retrograde urethrogram. You can see the X-ray dye going in, and then right here is the scar. Then it opens up again. And then this is the kind of image that we get with our ultrasound. And we see in this case the actual scar is actually pretty long. It's almost 3 centimeters. And so in this case we might elect to use the buccal graft urethroplasty. So a lot of times when we discuss doing urethroplasty in clinic, I would tell a patient that had a scar like this that we'll do an ultrasound and we'll figure out whether we can just cut out the scar tissue and reconnect the urethra, or whether we have to use a strip of the inner cheek to rebuild the urethra. And I might give the patients a general idea. The way it looks to me, I think we can cut it out, but we may need to use buccal graft urethroplasty, or this is a really long stricture, I can see that, it's really obvious on the X-ray, we're definitely going to have to use the buccal graft. This is another image. Here, the retrograde urethrogram was done, but you can't tell how long the stricture is because this portion of the urethra up here never really got distended. And so the ultrasound that we do before the operation can really help us because we're able to distend this urethra and really measure. And in this case, this is a really limited stricture of just about ½ an inch or so that we can easily just remove the scar tissue and reconnect the urethra. So what are some of the things that predict for success versus failure of urethroplasty? This was a very nice paper done from San Francisco and by Dr. Breyer and Dr. Makinich. And we looked at the patients and the number of medical problems they had and whether it predicted a worse outcome from doing a urethroplasty. And the significant findings in this were smoking. And so we always encourage patients that are undergoing urethroplasty to stop smoking for about 4 to 5 weeks before the surgery. Prior internal cutting surgery also predicted a worse outcome. And this may be because these patients didn't just have one, they had many of these internal cutting surgeries, and the strictures were much longer and harder to deal with. And then also failed surgery in the past. In other words, another urethroplasty that didn't work, and then the patients had to come back for additional surgery. And that's pretty intuitive that that would make the additional surgery a little bit less successful. In other papers, the factors that predicted a worse outcome were a history of hypospadias repair, and then this interesting skin condition called lichen sclerosis, which is just an inflammation of the urethral mucosa that's very hard to treat. Older patients had a worse outcome. Radiation also had a worse outcome, and that's because the radiation really damages the surrounding tissue. And then patients that were overweight also had a little bit of a worse outcome compared to thinner patients. How do we measure the outcomes after urethral surgery? And there's a few ways to think about them. We categorize them into anatomic outcomes and then functional outcomes. And the ways you can measure anatomic, meaning that the urethra is actually open and we're able to either pass a catheter or a cystoscope through the area without any impedance, or you could do an X-ray and look for any narrowing of the urethra. The real measure, one real measure of outcome though, is a functional outcome. And this might be, how does the patient feel afterwards? Is their flow better than before surgery? And that would be a measure of their symptoms. And then you could also measure, do they need any procedures or additional surgery? And so the papers in the literature are a little bit different how they measure things. So in other words, if you look at just the scope outcomes, you'll find some men that have narrowing, but it doesn't really bother them. They don't notice any symptoms. And you say, well, your surgery hasn't worked out perfectly. And these men might say, well, what do you mean? I'm peeing better than I've ever peed in my life. It's worked out great from my perspective. And that's because it really has to narrow down to that pinhole, or be very narrow before men have a lot of symptoms from their stricture. So those men, for instance, we might follow a lot more closely. The reason I mention this is that the studies really vary, and some studies will quote greater than 90% success with urethroplasties. And it's true, if you define this as not needing another urethroplasty, then yes, it's greater than 90%. However, if you define this as some narrowing that you see on a scope procedure, then the success rate is going to be less, even though patients may not have symptoms from the scar. As I mentioned, the outcomes in the literature are really great. For urethroplasty, they're greater than 90%, although the caveat is what I mentioned before, is a lot of these outcome measures are based upon clinical outcomes, not necessarily the anatomic outcomes that I mentioned. Well, urethroplasty can be a very successful way of treating urethral strictures. Generally, patients have undergone an endoscopic procedure, like that internal cutting procedure, or a dilation before. If they've undergone that and they want to go on to urethroplasty, urethroplasty offers a very successful way of treating the stricture long term. Well, that was a lot of information about the background of urethral strictures. Urethroplasty offers a very viable option if you've undergone internal cutting surgeries or dilations and they haven't worked to relieve your symptoms. It's a more invasive surgery, but fortunately it's a more successful surgery than the internal cutting surgeries or dilations.